Good morning, good afternoon, good evening, everyone. Welcome to another VMR case. My name is Aisha, and I have the pleasure of co-discussing with Rabih. I'm so motivated by him. I joined CP Solvers about 5-6 months ago, and I've loved every single session. And I look forward to the case today. Our case presenter is Tansu. Tansu, welcome. And she's recently joined us. Would you like to introduce yourself?
Sure. My name is Tansu. I'm from Turkey. I went to medical school in Turkey, but after medical school, I moved to New York. Now I live in New York City, and I'm doing research at Mount Sinai, and I'm very, very excited to be here today.
Amazing, y'all. I'm trying to time my yogurt bite, which is a very poor trick. I'm out of form. Aisha, I think that you've literally taken VMR by storm, and I think you loved every single session because you've been at every single session since I think you you joined, which is so telling. And we're thrilled to be able to celebrate your contributions to VMR by nerding out together. And I think the same goes for Tansu. I feel like you've been such a VMR regular that it's such a delight to have you present a case today. I imagine Shema probably pays a little bit more attention than I do to see if we've had a case presented from Turkey, but I suspect you're our first one. Is that right, Shema? Yeah. Wow. You got a whole weight of a country on your shoulder. I'm kidding, of course. But where in Turkey did you go to medical school?
In Istanbul, Marmara University, specifically.
And can you tell us a little bit about what medical school is like in Turkey? How long is it? What's the typical experience?
Sure, it's for 6 years, and the first 3 years are preclinical years, and then the next 2 years, fourth and fifth years, are the clinical years for clerkships, and then the last year is the internship year. So we take on the duties of a regular, normal doctor. We do everything, and then that's it. At the end of 6 years, we graduate.
Amazing. And so your last year is basically you take on all the duties in all the different departments, like internal medicine, family medicine, surgery,
pediatrics, surgery.
Oh, yeah. Incredible. Do you miss practicing now, or how do you feel about being in research?
I do miss practicing, and I'm really looking forward to getting into a residency program and starting my training.
Are you
next
applying
year, hopefully?
You're applying this year, is that right? And
yes.
Then okay, wonderful, awesome. Well, we have the whole CP Solvers community rooting for you, and very, very excited for your future career. Aisha, you ready to rock and roll? Okay, take it away, my friend.
All right. So today we are going to be working on a patient whose presentation was for fatigue and blurry vision. I saw this patient as an intern in medical school last year, and I was in a specialty outpatient clinic within my university hospital. The patient was a 40-year-old woman who had fatigue and blurry vision and glary vision for years, but her symptoms became life-limiting at this point while performing her daily chores. That's why she's here today. She came to the clinic. And I will just stop here if you want to elaborate on that.
Okay, what an amazing case. Okay, so we have a 40-year-old female presenting with fatigue and blurry vision for years, and symptoms have been life-limiting. So when I think about fatigue, one of the first thing that I think about is iron deficiency anemia, just because a lot of patients don't tend to consume too much iron, and if she's a female, she also can lose iron in her menstrual period. And thyroid disorders can also cause fatigue. Hypothyroidism can be another cause of fatigue, or chronic medical conditions or inflammatory conditions can cause fatigue in this patient. If she's in a reproductive age, so autoimmune disorders can also lead to fatigue. And we also have to consider her lifestyle factors. Does she have a poor diet? Does she have any physical, is she doing any physical activity? How is her alcohol consumption? Is it excessive consumption? What medications is she taking? A lot of medications can cause fatigue as well. And I would be more concerned here about the blurry vision. I want to know when it started. Is it unilateral? Is it both eyes? Is it just one eye? Does she see any floaters? Is there any double vision? Yeah, and if there's any pain recently, and yeah, what do you think, Ravi?
I think that's awesome. Just to not to reflect on the details of what you said, but what your mind immediately did is you just had a lot of questions. And I think this is actually what we talked about last week with Marino about trying not to solve the problem, but identify the problem. And I think if I were to guess what happened, I think you went into like VMR, a little bit nervous mode, and mentioned the first things you mentioned were a specific diagnosis, iron deficiency anemia. And then you're like, wait, what? I don't really know what this person has. And then you started to get broader and broader and broader and broader. And I really commend you for doing that, because there's no way that you could look at this unless you're forced to take step 1 or step 2 and start to think, what is the answer? You know, in real life, you would be like, well, what does she have? What kind of fatigue does she have? What is the context for that fatigue? And it was so cool to see you go from like step 1, step 2 mode to like real life, very wise, authentic practice. It happened before our eyes, and I think it's really, really cool. And I'm right there with you. I think that there has to be a lot of questions about the blurry vision and a lot of questions about fatigue. And I think this is where being a global community is very, very helpful. And we don't know, of course, the context in which patients use specific language in Turkey. But in general, when somebody's using the word, when a native English speaker is using the word fatigue, you have to be a little bit careful, because fatigue can mean that I am fatigued because of all the reasons that you mentioned, Aisha, including thyroid issues, hormonal issues, iron deficiency, or it can be a loose description of exercise intolerance. So what the patient may be trying to say to you is that when I walk and exert myself, I get fatigued. Contrast that to I feel fatigued all the time, no matter what I'm doing, and I'm not any more fatigued sitting here than I'm not more fatigued while I walk. So Aisha, if you had to think off the fly, what do you think would be different with a patient who says, I'm fatigued all the time, versus a patient who's only fatigued when she walks? What would that do for you? And how would that change your thinking if we get that information subsequently?
I think if the patient says that she only gets fatigued or when she walks, I would be thinking more of neuro etiology rather than systemic.
100%. It's almost like you have to ask yourself, well, what's unique about walking that makes somebody feel some problem? And in order to exert yourself, you need the neuromuscular and osteoarticular apparatus to work, right? You need the nerves to start to move the muscles and the joints to move smoothly. But what you also need is power and fuel to the nervous system to be able to do that. And so when I think of fatigue with exertion, I think neuro is the real action step, but neuro does not move without oxygen and glucose. And what gets oxygen and glucose to the nervous system? It's the cardiopulmonary apparatus and the blood system. So it'll be really, really key to try to figure out, is this with exertion or is this at rest? Especially when you're getting a sense that it's inhibiting daily chores, and whether that's because as soon as she starts to do something, she still feels fatigue. That'll be really, really important. I also agree with all the caveats that you ascribe to blurry vision, and I'll add in another one. When patients complain of visual complaints, you have to then translate those words into objective perturbances. Blurry vision to a healthcare professional means that there's something in the way obscuring the quality of the image. So there's no loss of vision, but the quality of the image is fuzzy. It's no different than having an old computer screen that's poorly pixelated. You can see everything on there, but you don't see it well. Visual loss is that there's a crack in the screen and half of it, you can't see anything. So it's going to be really important to try to articulate what she means by blurry vision, because if there's loss of vision, that's a very different landscape than blurry, i.e. it's fuzzy. And I got to tell you, there are many, many times where patients use those words interchangeably. When somebody says blurry vision, it's almost always something in the eye obscuring the actual quality of the picture. If it's a visual loss, then it might be in the eye, like the retina or optic nerve, but it also might be in the brain because you might have a stroke in the occipital lobe, so on and so forth. So we need a lot more information. I think as you did, trying to understand the problem will take us much further than I think what we have so far now. Any thoughts come to your mind since I've taught for a little bit, or anything else you want to add, Aisha, before we move on?
I think it's a good way to think about it, that where exactly in the neuro, and if there was any nerve damage, it's important to consider the specifics there as well. But you have good points. Tansi, can you give us the next output, please?
Of course. So I think we'll find most of the answers in the patient's HPI, and I will present so much history, but I really try to compact this in the best way possible. So 11 years ago, the patient was seen in a dermatology clinic for spontaneous facial freckling, and some blood testing was done at the time. The only significant lab abnormality was ferritin, which was 964. And further investigations were done, and diagnosis was reached. This will be discussed later. And she started on a treatment regimen accordingly. And then 9 years ago, the patient started experiencing fatigue, gradual onset, constant blurry vision in both eyes. And she went to an ophthalmology clinic and was told that she had an early phase of bilateral cataract, not requiring immediate operation. And thereafter, she stopped the initial treatment and was lost to follow-up for 7 years. And then 2 years ago, the patient returned for continuing care because she was curious how her presumed diagnosis was progressing, and her fatigue improved during this time. A new set of tests were done, and her labs again showed a ferritin of 1,218. So the same diagnosis was accepted and a different treatment was started this time. But 6 days after the initiation of the new treatment, the patient started having stomach aches. And on the 6th day, her husband was present at home with her. He reported that she vomited once that day and became unresponsive, lost consciousness after vomiting, and she was also contracting her upper and lower extremities. He alerted the EMR team, and she was brought to the emergency department in an outside institution. And I was able to obtain her hospital discharge summary. We could see that upon arrival in the emergency department, the patient was still unconscious and still had tonic-clonic movements, and supportive measures were taken for sedation and seizure control, but she developed respiratory insufficiency and was intubated. And then she went extensive workup with EEG, neuroimaging, CT and MRI of the brain, and whole body imaging, but these did not detect any underlying abnormalities. And it was decided that this could be an isolated incident of status epilepticus because of treatment side effects. And after the medication was stopped, the complaint subsided, and the patient did not experience stomachache, vomiting, or any further seizures. And I can just stop here to let you elaborate on this.
Oh my gosh. Wow. Aisha, I'm going to jump in here because I think what you're probably feeling is what everybody's feeling, which is what? And the truth is you have to digest two things. Not only are you digesting a complicated course, you're also digesting a complicated course in a patient without a clear answer. And that's really, really hard. So I think Nara's pretty troubled by this too. I'm curious. What we really should practice is not trying to solve this data, but to continue to practice how we've uploaded it. So I'm curious, where is your mind at in terms of what you've uploaded so far as helpful or important information? What has latched onto your brain?
So looking at the data, I think the ferritin is, the high ferritin is a little alarming. So that makes me kind of think of more on the side of hemochromatosis that could be possibly causing increased ferritin levels, the seizures as well. But then again, when you look at the seizures and then eye symptoms, that also makes me think of neurocutaneous disorders as well.
Nice.
And the stomach aches, that goes for hemochromatosis. So I'm just, there's a lot of information.
Yeah.
So I'm just trying to categorize where where I'm looking at. And so the eye symptoms makes me want to think of, was there any so in neurocutaneous, I'd be thinking of any Lish nodules, optic gliomas, or anything of that sort.
No, I love it. I think that you clearly have latched onto the ferritin and you've latched onto the freckling plus the neuro syndrome, right? Like those two combinations are key. Tansu, I really commend you for the setup that you're doing here, because I think knowing how to present such a complicated case like this is really, really tough. And the fact that you've chosen to sandwich all this as one piece of data really allows us to analyze it with more clarity and with more confidence. And I think, Aisha, one thing for us to add to the list of things we should analyze is how Tansu is really emphasizing that all the neuro dimensions resolved after she stopped treatment, which we don't know yet, for her presumed diagnosis for the ferritin issue. So how does that final piece, as we make a list before we study it, we're going to study ferritin, we're going to study neuro stuff, but then we have to try to see if we can make it easier by saying, well, what do we make of the fact that the medication was stopped and her neuro symptoms improved? What does that do for you?
I'd be thinking it could be due to the medication. It could be medication induced if she had. I think I missed what medication she was given.
I think it's deliberately camouflaged.
Yes.
Oh, okay. 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 I think it would be medication induced.
What's that?
I think it would be medication induced if it improved after her finishing the medication.
Yeah, I think that's the most likely possibility. The other thing always to worry about is substitute the word induced with triggered. And I think that many medications alter the seizure threshold, but do so in a patient who has a pre-existing vulnerability to having this issue. I just actually took care of a patient yesterday, and you'll see why this is coming up a lot, because we're going to talk about it for Academy VMR. But the patient had a congenital long QTC, but they've had that congenital long QTC their whole life. The reason I met them was they got hypokalemic for another reason, because they had diarrhea, and that, guess what that did? That made their QTC even longer, and then they went into torsade. So we have to be a little bit careful not to prematurely say, oh, this is just the medication alone, and forget about it as a complication of the medication, which is actually, as you said, most likely. But there's also a possibility that the medication brought about something to the surface that was already brewing, and then the medication's gone, but the disease is still under the surface, and it may remain under the surface forever, or it may start to inch closer and closer without the medication needing to trigger it. So I think you're right. Let's study the skin, let's study the ferritin, and then let's still study the seizure stuff, in large part because we could be dealing with medication-induced or medication exacerbated issues. So you went from, let's focus on the ferritin for a sec. So you went from ferritin to hemochromatosis, which is awesome. Can you tell us a little bit more about your illness script? What else do you know about hemochromatosis?
So hemochromatosis causes signs and symptoms all across the body. It can affect neuro, it can affect abdominal, it can be in parts of the body, in a lot of parts of the body. Yeah.
It is a multi-system disease, 100%. And what would you say is the pathophysiology? Like, what is the fundamental? Why is it a systemic disease? What's the underlying pathophysiology and what's happening there?
It's due to the overload of
Beautiful.
iron in the body that accumulates either due to the reabsorption from the GI reabsorption or decreased excretion or increased intake from diet or iron supplements or yeah.
Yeah, no, 100%. You nailed it. There's basically no regulation on iron absorption in the GI tract. There's no stopping any iron that we eat, and it all gets absorbed basically. And so that's why it's a systemic disease with many manifestations, basically from head to toe, with the neurological manifestations being mostly pituitary in nature, not quite the seizure phenotype that we're seeing here. So now that we thought about that hemochromatosis is an iron overload syndrome characterized by high ferritin and multi-system disease, what tools do you have in addition to the ferritin to help you wonder, is this patient iron overloaded? What would help you with that?
I would look for the transferrin levels
in
the body and just see if, of course, ask her her history, if she is taking iron supplements, or to find the source of where the iron is coming from, because if she's a woman, it's less likely for them to have iron overload because of menstrual period, so they tend to lose it anyways. So what's exactly causing this excessive overload?
There you go. I was going to try to walk us there, but actually you were 4 steps ahead. This patient cannot have hemochromatosis. She's too young. She's a 40-year-old woman. Could she have hemochromatosis? Yes, she could have a very small genetic variant of hereditary hemochromatosis that's early onset, but that's very, very rare. So you already slammed the brakes on hemochromatosis by saying, yep, the ferritin's high, but we don't know the percent SAT, which is needed for a high ferritin to be attributed to iron overload. And a 40-year-old woman having hemochromatosis, possible, exceedingly rare. So I guess, Aisha, the question for us now is to try to scratch our brains for other causes of a high ferritin that may not be from hemochromatosis. So that list is unfortunately like esoteria, not necessarily fair game for common knowledge. But since you've been on VMR a lot, I'm curious if you've seen other causes of high ferritin.
High ferritin.
Yeah.
I'll come back to you on that. I can't
think
of
yeah, I'm sure. I mean, that's the whole point, right? These are to help you grow. But yes, ferritin is an acute phase reactant, and there are many, many causes of high ferritin that result from high inflammation. So a helpful way to break down high ferritin is to break it down with inflammation or without inflammation. And many causes with inflammation can cause a high ferritin, though we tend to disproportionately see a super high ferritin in Still's disease and in hemophagocytic lymphohistiocytosis, or HLH. Those are the two big ones. I think it's also important now to add COVID-related inflammation as a cause of high ferritin. So there's really 3 important ones: HLH, Still's, and MIS-A, multi-system inflammatory disease related to COVID, A in adults or C in kids. And then there are a whole variety of non-inflammatory causes of a high ferritin. I don't think I can share the high ferritin schema with you because I suspect it contains the answer to this case, and I don't want to prematurely reveal it. But I think you're on the right track. Analyzing what causes a high ferritin, not jumping to hemochromatosis because the patient's probably too young to have a common version of hemochromatosis, and then studying all these other things that are accompanying it, including the seizures. The freckling will be really, really important. But we've talked about a lot. I just want to bookmark one thing that's pretty unusual too in a 40-year-old woman, which is that she has bilateral cataracts. Any thoughts, any reflex thoughts on that? Like what would cause bilateral cataracts in a 40-year-old woman? This is esoteria. So my answer would be, I don't know what to do with it, but it's weird, but I'm curious what your answer is.
I'm thinking, when I think of cataracts, I think of prednisone as one of
Nice.
the big
Mhm.
medication that causes it. She's a pretty young female, so I wouldn't really consider aging as the cause. Was there any UV exposure, high UV exposure, or did she have any eye infections previously that might have led to her cataracts? Diabetes is one of the bigger ones. And yeah.
Superb. Spot on. That's exactly right. I think those are the things we should be thinking about. Steroid exposure is the big one. Trauma can do it too. And then a whole variety of genetic conditions can cause early cataracts, but it's very, very unusual to have cataracts at 40. And now I don't know if we need to look hard for other explanations of the blurry vision. So the blurry vision is probably under the cataract, and then everything else we still have to try to figure out. All right, Tatsu, tell us more. We're very intrigued.
Okay, so the next is the background data. This patient did not have any prior past medical history, no prior surgeries, and she wasn't on any medication, including over-the-counter drugs or OCP. She didn't have any allergies, and she denied any alcohol, tobacco, or other substance use. But in her family history, her father passed away at 62 due to a stroke. And patients' aunts and cousins on the maternal side have been suffering from bilateral cataracts, as well as the patient's sister and niece who required bilateral cataract surgeries at the ages of 38 and 16. And I can briefly pause here.
What do you think, Aisha?
So I find the family history very concerning, that there is a family history of cataracts. That could help us with our diagnosis, but I don't think I can think of any other diagnosis with the rest of the family history.
Yeah, I know 100%. I think that you really lock into the idea that that there is a hereditary cataract syndrome. So now I think you can start to be confident that this person has a genetic component to her disease process with the cataracts. But whether that's the entire picture will have to remain to be seen. But yeah, the combination of it being the patient being so young and the family history is very suggestive of a genetic cause for sure. But I think it would be premature to assume that everything you were dealing here with is genetic. All right, Tansu, tell us more.
Right. So her vitals were normal. So her temperature was 36.7, heart rate 85, respiratory rate was 20, and blood pressure was 100/60. In the review of systems, she appeared in no acute distress. Her neck was supple, no lymphadenopathy, but her conjunctiva was pale. And she had regular rate and rhythm in the cardiac exam, chest clear to auscultation, abdomen was non-tendered, non-distended, no masses, no organomegaly. Her neuro exam was also normal. She was alert and oriented with normal speech. She didn't have any edema on her extremities or anything, but her skin was notable for pallor, and she still had facial freckling. But otherwise, the rest of the exam was normal. And then I can go on to the labs here or pause.
Yeah, maybe we can get the labs too.
Okay, so I have a very extensive data for the labs from the outside hospitals and the labs that we got, but I will just compact this again. And the patient's CBC was trended over time, starting from 11 years ago. Her hemoglobin was normal at first, but it fell over time. And her white blood cells and platelets were normal all along. Today, her hemoglobin was 8.3. Her MCV was 61.5. White count was 7.5. Platelets 514. And her vitamin B12, folate, TSH were checked and they were all normal. And she had a normal complete metabolic panel and normal coagulation studies. What other labs would you like to know at this point? I can give you more labs.
Super helpful. What do you, yeah, go ahead, actually, sorry.
So did we have any ferritin levels or transferrin levels?
Yes, so her ferritin today, it was 1,399, and it was trended over time since 11 years ago. And it peaked at some point at 2,678, 2 years prior to this evaluation. And her total iron binding capacity was 492.
Her low MCV 61.5 really makes me, which is microcytic, really makes me go back to either anemia of chronic disease, iron deficiency, more rare, but lead poisoning in this, but lead poisoning, I would put that way lower on the list.
Yeah, no, it's amazing. Sorry, go ahead. I thought you were, but you were thinking, I thought you paused. Go ahead.
Her physical exam looks pretty normal, except for the pale conjunctiva, again, which could be because of the anemia as well. Everything else looks normal. And then the facial freckling is coming back again. So that makes me want to think of neurocutaneous again. So
that's amazing. It's so cool that you latched onto the MCV as the first thing you want to discuss, because I agree with you. It's the most important thing. And you outline your differential diagnosis of it being related to iron deficiency, anemia of chronic disease, lead poisoning, and then we'll add in thalassemia as the final cause. And you can separate the cause of low MCV by acquired or congenital, with acquired being iron deficiency, anemia of chronic disease, and lead poisoning, and congenital being thalassemia. And that approach is helpful because if you have another CBC and you see that there is a change in the MCV, you then almost eliminate the idea that it's thalassemia, because thalassemia will be congenital the whole time. So Tansu, do you have a sense of what her prior MCVs have been? Have they been static at 61 or have they been declining?
They were higher at the beginning, 11 years ago, and they were declining since then.
Amazing. That's super, super helpful. So Aisha, what do you think? Iron deficiency, anemia of chronic inflammation, or lead toxicity? What do you think you're gonna lead with? What would be your most likely cause?
So, and if I were to put them in order, I would say anemia of chronic disease, iron deficiency. I think the case is so complicated. I think anemia, iron deficiency is too much of a simple of an answer to be the diagnosis.
Yeah, you know, I always recognize the impetus to try to use context clues, the fact that we're at VMR and CPS, and it's a complicated case. But if you were to literally pretend this patient's right in front of you, what would be the reasons you would prioritize chronic disease over iron deficiency?
I think because of her other symptoms that she's had for many years.
Yeah.
She had a lot of neuro symptoms. She has and her ferritin levels.
Yeah, 100%. I think the easiest answer to be like, how can I invoke iron deficiency when the patient has a ferritin of 1,300 or over 1,400, right? How can you do that? The problem is that anemia of chronic disease is actually very poorly named. It's not anemia of chronic disease. It's actually anemia of chronic inflammatory disease. And the problem is that we have no evidence of inflammation. She's not lost any weight as far as we know over 11 years. She looks well over 11 years. Her white count is normal and her platelets are normal. So Aisha, you have a very, very tough analysis to do because you have acquired microcytosis, and the two most common causes are iron deficiency and anemia of chronic disease. And you have two overwhelming reasons to doubt both of them. The ferritin is super high, making a strong argument against iron deficiency, but there is zero signs of inflammation. So that should make you think, okay, wait, should I entertain the possibility of the third thing that you didn't want to entertain, lead toxicity? And you go back and you're like, wait, hold on. She's got stomach aches. She's got neurologic symptoms. Could it be lead poisoning? But then I'll throw that out the window, because if you've had lead poisoning for 11 years, I guarantee you're not going to look well. No chance. So I think we have to ask ourselves, which of the two counter arguments to our hypotheses should we try to work with? Should we try to look for causes of iron deficiency that can have a high ferritin? Or should we look for causes of anemia of chronic disease without much inflammation? What do you think?
I think that's a really good question. Now I'm starting to think lead poisoning should have been higher up on my list.
I don't think so.
No, you don't think so?
No, 11 years of lead poisoning? Oh my gosh.
No.
Yeah.
Okay, yeah. I'm just a little confused.
Yo, how could you not be?
The case is all over the place. It's an amazing case, Tansu.
Right.
Thank you.
I'll tell you to try to part of the goal with practice and with doing this for 15 years is seeing simplicity. This is a complicated case, but can be distilled down to one question. Is this case iron deficiency with a high ferritin? Or is this case anemia of chronic disease without inflammation? That's
I think anemia of chronic disease without inflammation.
Okay, great. I love that. What if I show you one slide? I'm just going to put it up and I want you to look at it. And then you tell me if this changes your mind or if it reinforces what you're thinking. I'm going to leave it up here for a minute, okay? What do you think?
That there's hereditary increased ferritin with cataract. Well, what is that doing there?
I know, right? I think that's the key question. So this is the power of VMR and reflection and whatnot. And we've had many cases of tricky ferritins, and they prompted me to read about ferritin. And in my reading, a Hemochromatosis condition, which basically is that the ferritin is constitutively expressed and no longer a function of iron, no longer a good measure of iron stores. And so what happens to these patients all the time is that the high ferritin prompts a diagnosis of iron overload. The patient gets secret medication or secret treatment, phlebotomy, or an iron chelator. Guess what a side effect of iron chelation therapy is? And that triggers iron deficiency. And the patient then has pallor and microcytosis and whatnot. So I'm a little bit worried that this is a rare situation where the ferritin is no longer telling us an accurate proxy of iron stores. And when coupled with the patient's cataract and the family history of cataract is concerning enough for this rare but important to know genetic condition, which teaches us a lot about ferritin and its pathophysiology, that it can be completely independent of iron stores. So it's a very, very tough case because it's pushing you to unlearn something you've probably locked in, which is ferritin tells me what iron stores are. But that's not always true, you know? So, yeah, I think in the absence of any robust inflammation and this one factoid, we now have no argument against iron deficiency and can see a pathway where a ferritin fooled many of us into thinking this person has iron overload, but her young age was a clue that that's not a case. And the presence of cataracts in the family and her reinforces the possibility of this rare condition. So I think the percent saturation of iron can help you. And another clue is to give the patient iron to see what happens to her MCV and her hemoglobin, of course, followed by testing for this rare but important condition. What do you think, Aisha?
I think I haven't heard of that diagnosis before, but it does make sense. And I'm really interested in learning a little more about it.
Yeah, absolutely. All right, tell us more, Tansu. Please.
Amazing conversation. I'm learning a lot listening to you. So, as I said at the beginning, when the patient first presented 11 years ago, her very high ferritin prompted an evaluation of all the known causes of hyperferritinemia, and her hepatitis acute panel was sent. Her Hep A IgM, Hep B surface antigen and core antibody, and Hep C antibodies all came back negative. And her HIV antigen antibody combination immunoassay came negative. Hemoglobinopathies were ruled out with hemoglobin electrophoresis, and she was referred for genetic testing for hereditary hemochromatosis. And so she was tested for the two major known mutations for hereditary hemochromatosis on the HFE gene. Her genetic testing came back positive for H63D mutation, and she was homozygous for it. And diagnosis of hereditary hemochromatosis was made based off genetic testing. And then the patient was started on phlebotomy on an as-needed basis based on her iron status, which was monitored with her serum ferritin. And phlebotomy induced iatrogenic iron anemia in this patient. And the patient was getting more and more fatigued after phlebotomy. That's why she discontinued her treatment completely for a while, which was good in retrospect, actually. And then she came back 2 years ago before her current presentation, and deferoxamine was started because of patient's non-compliance with phlebotomy and her elevated ferritin, but otherwise anemia indicating labs. And during her hospital stay, after she lost consciousness, the team that was taking care of the patient thought, since she had a genetic confirmation for hereditary hemochromatosis, her loss of consciousness and tonic-clonic seizures could be explained by hereditary hemochromatosis. That's why more investigations were done, but nothing was found. No total body iron overload signs. Non-contrast hepatobiliary MRI showed no iron overload. And whole body imaging was also normal. And deferoxamine was seen as the culprit, and it was discontinued as a result. So I can pause here before I reveal the final diagnosis to hear your thoughts on why this patient still had hyperferritinemia and cataracts.
I just wanted to throw a caveat to all this. I think you are discussing quite possibly the hardest case to discuss I've ever been involved with. That's just not VMR. That's every single real life case that I've ever discussed. I just want to throw that caveat out there that if you are not covered in sweat, if your heart rate is not 190, then you're doing fantastic. I'll just say that.
Thank you very much. This is definitely a case I've never seen before. But looking at this, when I think of hemochromatosis, the reason I didn't go for, I mean, I was a little bit on the hemochromatosis side and a little bit not, was because a lot of patients do present with like cirrhosis, or a lot of patients say that they have bronze skin. That wasn't seen in this patient. There's a lot of patients that present with symptoms of restrictive cardiomyopathy. But yeah, that's what that was where my mind was at.
As it should be, as it should be. You're dealing here with the ultimate con and the ultimate setup. This case cannot be diagnosed any more efficiently, I don't think. And I'll just share my opinion. I'm really curious to learn from Tansu and how she put this together. I'm just dying on the inside because I saw Maima's comment that she would just turn off her Wi-Fi. Oh, Maima, I don't know if you should have revealed that card. Now we know if Maima vanishes, we know what happened. Anyway, so iron overload. We diagnose iron overload by laboratory assessment, where the percent saturation of iron is greater than 45 in men and greater than 55 in women.
we have to repeat that test twice to confirm because it's a noisy test. And the percent sat gives us insight into the serum iron overload status. And the ferritin gives us a sense into what the levels of tissue iron are. So in most patients, the percent sat is elevated. It triggers a ferritin analysis, and those two line up, both elevated, to suggest the patient has an iron overload syndrome. And as Tansu just taught us, there are often two things at play that cause iron overload. The first is a genetic disease, such as hereditary hemochromatosis and a few other ones, very rare. But in most patients with hereditary hemochromatosis, they also have a secondary trigger that exacerbates their iron overload, including the 3 H's, HIV, Hep B, and Hep C, and also alcohol consumption. So most patients with iron overload either just have secondary causes without a genetic disease, like Hep C and alcohol, the two biggest ones. A fraction of patients will also have a congenital disorder. So when you're searching for the cause of iron overload, you first look for acquired factors, hepatitis C and alcohol being the biggest ones. And if you don't find anything, you then look for a genetic cause and do a hereditary hemochromatosis analysis. That's the arc usually. What happens if you find an acquired trigger? Well, what should happen is you treat the acquired trigger and see what happens. Alcohol cessation, Hep C treatment. And if the patient resolves, you're done. If the patient has continued iron overload despite treatment of the trigger, we usually pursue genetic testing for hemochromatosis. Don't get me wrong. There are sometimes some early clues that a patient has both an acquired condition and hemochromatosis, but that's not a topic for this time. So the most common pathway is we don't find a secondary trigger and we look for genetic testing for hemochromatosis. And this is the most important thing I'll say to you. Hemochromatosis is not diagnosed by genetic testing. Hemochromatosis is considered by genetic testing only to be diagnosed after treatment for hemochromatosis. And if the patient improves with phlebotomy, you can now line up genetic testing with the clinical syndrome and call the patient having had hereditary hemochromatosis. What happens if you get positive genetic testing, but the patient worsens with phlebotomy? They do not have hereditary hemochromatosis. Why? Only 20% of patients with hereditary hemochromatosis have phenotypic expression of their genetic disease. So what does that mean? That means 80% of people with the gene will not get iron overload. And that's the key fact in this case. 80% of patients with gene-positive disease do not have iron overload. So what do I think is happening here? The ultimate con. This patient has two genetic diseases: hereditary hemochromatosis and hereditary hyperferritinemia with cataract syndrome. Oh my gosh. I don't think that the hereditary hemochromatosis was phenotypically expressed by this patient. And as a result, she got iron deficient with phlebotomy. And her ferritin did not care because she had presumably had hereditary hyperferritinemia with cataract syndrome, which this is the most mind-boggling case I've ever considered in my entire existence, and probably will be. So that's my best explanation. I'm not 100% confident in it, but I'm really intrigued by the possibility. It seems so interesting. So before we learn from Tansu, this once in a lifetime case, I'm curious, Aisha, if you have any thoughts or any clarifications about what I just said.
No, I think you just gave us really good pearls. I'm just still trying to connect all the dots of what has been happening to this patient for the past 10, 11 years. But I do want to know what happens next in this patient.
Awesome. All right, Tansu, please connect the dots for us.
You are doing amazing, really spot on. So when I saw this patient's labs, I thought something was unusual because she had very high ferritin, otherwise anemia indicating labs. And I was fortunate that the hematologist attending was in the clinic. And he remarked on the patient's hemochromatosis history and current labs and blurry vision and lack of evidence for iron overload. So we asked the patient if she had any family history of cataracts and cataract surgeries, and she confirmed. So the hematologist attending immediately thought of hereditary hyperferritinemia cataract syndrome, which ended up being the final diagnosis. So as you said, it's a very rare genetic disease caused by a mutation in the FTL genome, chromosome 19. And there are over 100 cases reported up to date in the literature. And there are 30 variants affecting the FTL gene is identified, and it has an autosomal dominant inheritance pattern. So the manifestations are just a very hyper elevated ferritin without systemic overload, with or without cataracts, and it's not seen in every single case. It's also called benign hyperferritinemia. And we considered submitting the patient's blood for the FTL gene analysis, but availability and cost were barriers. And in the literature, we saw that when genetic testing was not feasible, if a patient had isolated hyperferritinemia without iron overload, with or without early onset cataracts in 2 or more family members demonstrating an autosomal dominant pattern, that was sufficient for diagnosis. And she already had that kind of inheritance pattern in her pedigree. And we also got confirmation from the ophthalmology clinic for the specific pattern of her cataracts, which was the same pattern reported in the literature for the HHCS cataract. And I actually sent some pictures to our scribe of the patient's slit lamp exam with direct and retroillumination. Can we see them? So in the retroillumination pictures of her lens, there are speckles of ferritin deposits, especially in the middle, right here. So that's why it's called nuclear cataract. And she had that type of cataract. And we advised that, so we got the lab results of the patient's 3 children. All of them had hyperferritinemia with otherwise normal iron indices. And all children also had 1 allele of the HFP H63D variant from their mother. And we made a referral for the patient's 3 children for the timely evaluation of early onset cataracts. And in 2 of her kids, also the same pattern of cataracts was confirmed. And we advised the patient that phlebotomy and deferoxamine were not the correct treatments for her condition, because she didn't have iron overload, and we prescribed the ferrous iron preparation to accelerate her recovery from her current state of iron deficiency. And it was an amazing experience to see the hematology attending identifying such a rare disease and changing our patient's life for the better. And he'll be watching this discussion later. I will share the link with him as well.
I think that was amazing, Tansu. Thank you so much. I think for this patient, it's so important for an early detection of the final diagnosis. It's important for a family to have continuous monitoring of any potential complications, just to prevent anything in the future in the children as well. But amazing case.
Thank you so much. It was a great discussion too.
I couldn't agree more. And Aisha, I really commend you for, tackling this case as your first time as a discussant is not easy. And I think the fact that you still have a smile on your face is just so symbolic of what we're trying to do at CP Solvers. We're trying to really just reflect the fact that all of us are diagnosing left, right, and center, no matter what we're doing. And I think it's unfortunately the illusion of pursuing perfection hampers us all, and we all are limited by the notion that we should do a perfect job every time, when the reality is none of us, even the people who have been doing this for decades, never even come close to perfect. And I really admire your resilience and your authenticity and the deep knowledge base that you have to help you navigate this very complicated case. And I think Tansu, I think there are two people who deserve a lot of credit for sharing this patient's journey. Of course, the esteemed hematologist who was able to suspect this, but I wouldn't underemphasize your tremendous role in this, because now infinitely more people are going to be aware of this and learn it, and will be able to maybe help probably the rest of the patients who have this genetic condition, because there are not that many of them. And yeah, I just saw in the chat that you've written this up as a case report, which is awesome. I can't wait. I don't know if it's this case, but if you've seen two of these cases, gosh, I'm really excited to read it, and really admire not just the dissemination of the learning, but presenting a case as complicated as this is very tough. And now I think both Aisha and I understand why you did not tell us the initial diagnosis and the treatment. And for all of you watching, it goes to show you how knowledgeable somebody must be to set us up for a richer conversation at the end, rather than kind of revealing the disconnect early on. We probably would have ended much earlier with much less learning had you not deliberately chosen to do that. So I really commend you. I learned a lot, and I'll be reflecting on this case all day long, probably, maybe even more. Thank you.
This goes to show how much research is still yet to be done on so many different conditions that are found in very less population, but there's so much more studies that need to be done. Thank you so much, Tansu.
Thank you both of you for the great discussion. Really, you figured it out really well. It was amazing to listen to you.
Thank you, Tansu. I'm so glad that Omaima's Wi-Fi is still working, because she pointed out something that it's ironic that I tweeted out today. I was reading about rare diseases, and they're very rare, but there's so many of them. And this patient had 2 rare diseases. Hemochromatosis is not super common, it's not rare. But yeah, I think it's very fitting that this case is presented today. Thank you. All right, Marina, you have the not so enviable task of summarizing the learning from this case. So I'm glad it's a seasoned expert like you. Take it away, my friend.
Well, congratulations, guys, for such an amazing discussion, especially to you, Ayesha, for tackling in such a hard case, but full of learning points. And I like to always say this, that it's not about the diagnosis, but the journey. And what an amazing journey you all had discussing this case. So right from the start, we got a patient, a 4-year-old female, that presented to the emergency department for fatigue and blurry vision. And the first thing that was discussed is that fatigue is a very non-specific symptom, but in this case, blurry vision could actually have helped us to look for a more to narrow down our differential, basically. So when we get fatigue for a patient, we think about a lot of things, and quickly into the discussion was thrown anemia, iron deficiency anemia, hyperthyroidism, and all kind of systemic diseases. But we must ask questions also, such as, is there fatigue at rest or fatigue with activity? So that can really help us to even narrow down more our diagnostic possibilities. So remember also to ask how the patient really defines the fatigue. I mean, many patients describe fatigue only as exercise intolerance and not about feeling like wobbly, wacky, or everything, or something like that. So when we think about fatigue with exertion, this patient didn't present it, but she didn't present fatigue with exertion, but many causes of fatigue with exertion are neurologic diseases, musculoskeletal diseases, cardiopulmonary system diseases, and also anemia. So how did we tackle on the blurry vision? So blurry vision is defined as a blurry vision, as a fuzzy quality of the image. So we shouldn't confuse it with loss of vision, which is the totally black out of the vision. And although many patients do really interchange the meaning of both of these presentations, so we should really ask them, how do they define their blurry vision? So later it was told to us that this patient had skin findings. So when we get a patient with skin findings, neuro findings, and also blurry vision, we must raise our alert to think about neurocutaneous disorder. She didn't present one of these, but they were really including the discussion for possible differentials. Later, it was found that her blurry vision was attributed to bilateral cataracts. So what are the causes, or what are common causes of bilateral cataracts? So we have steroid use, osmotic damage to the lens, such as diabetes, galactitol or sorbitol, deposition in the lens, UV radiation, and genetic diseases too. Later, it was found that also this patient had seizures. So there was this really amazing conversation about not saying that it is medication-induced seizure, but medication-triggered seizure. So a medication-triggered seizure can be seen in patients that take medications that lower the seizure threshold in patients that have certain predisposition to have seizures. Also, it is very rare to see hemochromatosis in a 40-year-old female. Remember that female patients get frequent periods, normally in a monthly fashion. So as they lose blood periodically, they tend to get lower iron levels and lower iron reserves. So that doesn't phenotypically express their hemochromatosis. One of the most important points of discussion during this presentation was the ferritin levels of this patient. So this patient had really high ferritin levels, and we classified hyperferritinemia as inflammatory versus non-inflammatory. So for the inflammatory causes, we have an acute bucket, mainly attributed to HLH, and also we have a chronic bucket of anemia of chronic disease or anemia of chronic inflammatory disease that it was told. And for non-inflammatory diseases, we got a bunch of rare diseases such as hemochromatosis, and the final diagnosis of these patients such as hereditary hyperferritinemia cataract syndrome. So in this patient, we got a major clue to help us think about possible genetic disease, and it was that multiple family members had similar presentations of the disease before. Later, it was found that also this patient had a very high iron overload state, but also, I mean, she had the hyperferritinemia, but she was iron deficient because of her low hemoglobin. So in patients with iron overload states, we need to look for triggers of iron overload. So these triggers are HIV, Hep B virus, hepatitis C virus, and alcohol, but she didn't have anything of this. One of the major pearls that I saw during this case was that this patient got genetic testing for hemochromatosis, and this genetic testing, for mostly of us, always thought that genetic testing was the confirmatory diagnostic testing for most of the genetic diseases. But hemochromatosis is an exception for this because only 20% of patients have phenotypic expression. So in the clinical picture of this patient, that she had a hemochromatosis, she immediately received treatment with phlebotomy. And basically phlebotomy really exacerbated more her disease. So diseases such as hemochromatosis are diagnosed only after seeing clinical improvement with therapy. As this patient got worse with therapy, we had to think about other possibilities that were causing her clinical presentation. At the end, everything was explained by the hereditary hyperferritinemia cataract syndrome, which is a really rare diagnosis, but basically consists of a mutation on the chromosome 19, and there's a lot of variants of it, but it consists of an autosomal dominant pattern. So that's what mainly explains that it was seen in every it was seen in every generation of this patient's family. So thank you for your attention, guys. And those probably were the most challenging teaching points I have ever had here.
Oh, I don't know what to say, y'all. It's such a treat. It's such a delight and such a unique privilege to do all this with you. Yeah, thank you, Marino. That was amazing. Thank you, Aisha. And a big round of applause for one of the most incredible case presentations I think we've had on VMR. Truly, big fans of you, Tansu. Best of luck with everything you do, and I hope to see you around, everyone. Bye.